This case was managed in 2023. It's about a 75-year-old female patient known to have hypertension for 15 years, had a Hancock 2 porcine tissue aortic valve replacement and mitral valve repair 2 years before her presentation. She had chronic atrial fibrillation and she was on apixaban 5 milligram BID, bisoprolol and digoxin, other medications, statin, furosemide, lansoprazole, and aspirin. She was referred to me by the surgeon who implanted this aortic valve in 2023 for new onset of shortness of breath for 5 days because he regarded that the risk of mortality is high if he takes her to surgery. When I examined her, she was not in distress. Her blood pressure was 160 over 100, and she had controlled atrial fibrillation. There was a loud ejection systolic murmur at the left upper sternal edge and mild bibasal crepitations. Of course, the EKG showed controlled atrial fibrillation. The echo showed normal left ventricular systolic function with moderate concentric left ventricular hypertrophy. At the level of the aortic valve, the mean pressure gradient was 55, and the max was 105 millimeter mercury, with effective prosthetic valve area of 0.5 centimeter square, indicating an obstructive pathology. The pulmonary artery pressure was, of course, was elevated. She was admitted to the CCU for TEE. As you see in this video clip, there is hypoattenuation of the leaflet thickness, and there was reduced mobility of the aortic valve, and there's a mass here that renders this leaflet immobile. The same in the short axis. The valve looks heavily loaded with the tissues. The leaflet is thick and the motion of the leaflet is reduced. And as you see, with the color flow, how the valve now is severely stenotic with this mosaic turbulence flow, color flow in the short axis and in the parasternal long axis. The same thing you see here. And these are the hemodynamics of the valve. The effective prosthetic valve area by velocity time integral was 0.5 centimeter square. We decided to give a low dose of tissue plasminogen activator of 25 milligrams slow infusion over 6 hours, followed by unfractionated heparin, and this was the result. Now, in the short axis, you see that the area of the valve now is larger, and the leaflets now are thin and freely mobile. The stenosis we saw before is no more there. Again, the leaflets are freely mobile. This is before, and this is after. Before and after. And these are the hemodynamics after the dissolution of the thrombus on the valve. The area now is 1.115 centimeter. The patient became asymptomatic after this. As conclusion, stuck prosthetic valves are uncommon but represent a diagnostic and therapeutic challenges. This patient was successfully managed by a thrombolytic agent with no complication. 1 month ago, she came for follow-up. She was asymptomatic and the aortic valve area is still 1.1 centimeter square. We shifted her from DOACs to warfarin. She was on DOACs for atrial fibrillation. In fact, now we decided to keep her on warfarin. Thank you.